Good afternoon, everyone. This is Emily Lemiska, Director of Communications for the U.S. Pain Foundation. Thank you for joining us. We're going to wait just a couple minutes more before we get started because we still have a lot of people joining. So just hold tight. We'll probably get started about 1:02. Hi again to everyone who's just joining. We're just going to wait another minute or so while people log in. So just thanks for your patience, and we'll start soon. Good afternoon, everyone. So it's 2 minutes after 1, so we're going to get started. Thank you so much for joining us today. This is Emily Lemiska, and I'm Director of Communications for the U.S. Pain Foundation. I just want to make sure everyone can see my screen.
Yes, this is Shana. I can see it.
Great, thank you. So we're really excited today because we're going to be hearing from Cindy Steinberg about the new recommendations from the federal government about pain. She's going to be talking about why they matter and how to weigh in. And I know that, everyone's aware this is a pretty big deal. So it's great that we can have Cindy to go through this with us. Once you've done giving us an overview of the report and how to comment, we will have a question and answer session for about 10 to 15 minutes. So just so you know, keep that pen and paper ready and jot down questions, and we'll try to get to as many of them as we can. Following the keynote presentation, we will have our regular department updates. So if you want to stick around for those will be at the end. Just some housekeeping items before we get started. You can ask questions at any time by typing them into the control panel at the right under questions. We'll answer the questions again at the end of the keynote presentation with Cindy and at the end of the staff update. We'll try to get to as many of them as we can. And one note, we will probably have a second webinar on this topic in February. So if we don't get to your question, know that we will see them and we'll try to answer them at a later time if we can. Also, we have 2 handouts available under the handout section of the control panel. One is the actual report itself. It's a PDF of that, which you can download. And the other is just some basic information and some links for commenting, which might be helpful to you. Please note that you have to download these before the webinar ends, but we will keep the webinar open for a few minutes after discussion ends so that you can make sure you've got those downloaded and are all set. Finally, if you have to jump off at any time, we will be recording this webinar and we'll provide that link in our next newsletter and on our website. And one more thing too, actually, once we close down the webinar, we will have a little feedback survey. And it's about 5 questions, and we want to hear from you guys about what you think of the report and what sort of resources we can provide you to help with commenting and understanding the report. So if you could answer that would be really great. So without further ado, I'm going to introduce Cindy. So Cindy Steinberg is the National Director of Policy and Advocacy for the U.S. Pain Foundation, Policy Council Chair for the Massachusetts Pain Initiative, and a nationally recognized leader in pain policy. In May of 2018, Cindy was appointed by the U.S. Secretary of Health and Human Services to serve on the Pain Management Best Practices Interagency Task Force That's a mouthful, which is what she's going to be talking about today. From 2015 to 2018, Cindy also served on the Interagency Pain Research Coordinating Committee, the highest-ranking pain policy oversight committee in the United States. In Massachusetts, Governor Charlie Baker appointed her to serve on his opioid working group, and in 2017, appointed her to be a commissioner on the Massachusetts Drug Formulary Commission. Cindy is the recipient of several accolades for her contributions to the field of pain management, including the American Pain Foundation's Presidential Medal, the State Pain Initiative Champion Award, the Grunthal Unsung Hero Award, and the American Academy of Pain Medicine's Presidential Commendation Award. In addition, Cindy was selected to receive the Mayday Pain and Society Fellowship for 2013 to 2014. Beyond her policy work, Cindy has run a support group in her area for nearly 2 decades. She does all of this despite living with very serious back pain. That's obviously what inspires her to work so hard on behalf of the pain community. So we're very lucky to have Cindy with us to chat about this task force and the report they've done. So Cindy, are you there?
I am here. Can you hear me?
Yes, we can.
Thanks a lot, Emily, for that introduction. And at the outset, I want to be clear that any views I express about the task force report are my own, and they don't represent the views of Health and Human Services or the HHS task force. Next. So my presentation today is structured around these questions so everyone listening gets a thorough understanding of why this report is important. So why was the report created? What was the charge to the Pain Management Task Force? Who created the report? Was there public input? What's in the report? Why does this matter? What does it mean for me? How does it differ from the National Pain Strategy? How do I get a copy? And how do I comment? And then we'll take questions. Next. So why was this report created? The Pain Management Best Practices Interagency Task Force, or I'll just abbreviate it to PMTF, grew out of the Comprehensive Addiction and Recovery Act. You may have heard it referred to as CARA. It was the first major federal opioid legislation passed in 2016. And the only section of CARA that pertained to pain was this one. It was Section 101 in the beginning of the Act. Congress wanted to know what pain experts consider best practices in pain management now. In light of the opioid crisis and the conflation of pain and substance use disorder, Congress really wanted to hear from pain experts. So that was why it was written into the Act. It is overseen by the Department of Health and Human Services. Next. This is actually the language of the statute. What was the charge to the PMTF? So the Secretary of HHS, in cooperation with the Secretary of Veterans Affairs and the Secretary of Defense, shall convene a pain management best practices interagency task force. The task force shall identify, review, and as appropriate, determine whether there are gaps or inconsistencies between practices for pain management, including chronic and acute pain, developed or adopted by federal agencies. And secondly, not later than 1 year after the date on which the task force is convened, under subsection B, propose updates to best practices and recommendations on addressing gaps or inconsistencies identified as appropriate, and submit to relevant federal agencies and the general public such proposed updates and recommendations. Next slide. So in plain language, what does that mean? So the task force's charge is really to update best practices and recommendations on pain management for the nation, including relevant federal health agencies, such as the Center for Disease Control and Prevention and the Food and Drug Administration, and many of the other health-related agencies. And the reason why the term interagency is included in the name of it is because Congress wanted it coordinated among other health agencies. So there is a representative on the task force for every one of the health agencies, and in addition for the Department of Defense and the VA. So out of those 29, approximately half of them are government appointees. Next. So who created the report? CARA was very specific about the types of experts that should be chosen for the task force. So in the statute, further along in the language, is a very detailed list of who needed to be included. Like, for example, a pain management specialist in acute care, or things like that. It said the type of person, type of expert they wanted. So there was a panel of 29, and they were all appointed by Secretary Azar. The chair is Dr. Vanela Singh, who is the Chief Medical Officer for HHS, and she sits in the Office of the Assistant Secretary for Health. So under Alex Azar is a few secretaries, one of them being the Secretary for Health for the nation, and Vanela Singh reports to him. I was the only patient and pain advocate appointed to the panel. Most of the appointees were doctors. Next slide. So was there public input? Yes. I mean, before the report work even began, even before the first meeting, the Federal Register said that there would be an open comment period of approximately 2 weeks. And just in that time period, we received over 3,000 comments, which was something they didn't expect and never thought they would get that many. The majority of them were from patients. Nearly 80% talked about difficulties accessing treatment. And I'm really thrilled about the pain community responding and writing in, because it made my job about how patient-centered this needed to be easier, because, I was outnumbered. I was the only patient there. So hearing from those patients was really important. There were also 2 public meetings. The first one, May 30th and 31st, which was the kickoff meeting, and that meeting sort of demarcated the 1-year clock. So unlike other committees, this one has a sunset. So we have to issue the report 1 year later, which was, really something that made us really work hard quickly on this report. The second meeting was on September 25th and 26th. And in both of those meetings, there was an open public comment period that was announced as required in the Federal Register. So various patients came and spoke. Others with a stake in the outcome of this came and spoke. There was also a phone line open, so they did take some comments from the phone. So there were definitely periods of time for people to call in or appear. In addition to that, Dr. Singh made sure that both meetings had patient panels. And so patients were chosen to speak at both of those meetings. And those meetings were videoed, so if anybody wanted to ever go back and look at them, they're available. The task force also reviewed the comments, the 3,000 comments we got over the summer. So the patient comments we had a consultant who reviewed them all and then picked out particular ones for us to read, and then they did sort of a compilation and sort of graphed and a histogram that really showed who responded, what the comments were about, et cetera. And then we read all of the sort of combination letters. So we received ones where multiple associations sent them in, or there were sign-on letters. And then the draft report was released on December 28th. Next slide. So why is this report important? What does it mean for all of us as people living with pain? So pain has never before been a focus at this high a level in the government. So, for example, the National Pain Strategy and the Federal Pain Research Strategy, which got a lot of press in the pain community, those were done under the auspices of the NIH. But the HHS office sits above the NIH and above all the federal health agencies. So FDA, CDC, AHRQ, SAMHSA, HRSA, all of them report in to HHS. The directors of all those agencies report to HHS. So this is kind of a level above anything that's been released before. It was also specifically mandated by Congress. So having been written into an act, a bill that became legislation is also pretty important. Therefore, the report is going to have some high visibility and the potential to really impact the practice of pain management in this country. And that's why it's really important for people with pain to weigh in on the report. We've never had an opportunity like this, and we may not get one again like this. So it's incredibly important. Next slide. So what is in it? The report is large. It's 91 pages, and it includes a broad range of topics: acute pain, medication, including risk assessment and overdose prevention, restorative movement therapies like physical therapy, occupational therapy, yoga, tai chi, and others, interventional procedures like nerve blocks, epidural injections, spinal cord stimulators, radio frequency ablation, all those kinds of interventions, psychological interventions, complementary and integrative therapies, considerations for special populations. So there are a number of special populations included, but examples are pediatrics, women, and the military. Stigma was a part of this. Public, patient, and provider education, access to care, including access to medication, and then medication and workforce shortages. And then there was a specific review of the CDC prescribing guidelines. Next slide. So, the report is large. It's 93 pages, but some of you may not have time to read all of it. So I wanted to provide kind of an overall sense of highlights that come through, having read the report and then step back from it. So the first, of course, is that pain is an enormous public health problem with profound individual and societal consequences. We in the pain community know that, but in the outside world, not so much. So I think it's important that that's stated right out front, and it is. Next slide. So the importance of individualized care. Successful management of pain requires individualization of care in the selection of therapies tried, in the consideration of risks and benefits of therapies, in the duration of treatment, in the optimal dosing of medication, and so on. And that's stressed throughout the report. I think it's also incredibly important that people realize one size doesn't fit all with pain, unlike some other more let's say, homogeneous diseases. Next slide. Multidisciplinary care is essential. It comes through in the report. Best practices in pain management is really achieved through a multimodal, multidisciplinary, integrated model of care, including a full range of pharmacological and non-pharmacological treatments. Next slide. Stigma. Stigma is a major barrier to treatment, so it's critical to provide education and awareness of the underlying disease process of pain and to provide empathy and a non-judgmental approach to treatment. Next slide. There just isn't enough education in pain available. The public does not have an awareness of what pain is, chronic pain in particular. Patient and provider education is really critical to the delivery of effective patient-centered pain management and is necessary for really optimizing patient outcomes. Next. And finally, an individualized approach to opioids as well. Opioids have a role to play in pain management, and the risk-benefit balance for opioid management must be considered on an individual basis, as there is wide variation in factors that affect the optimal dose of opioids. Next slide, please. So people have asked me, how is this different from the National Pain Strategy? So you can think of this report as an updated version of the NPS, but the focus is more pragmatic and more clinical on care now rather than in the future. It has been nearly 3 years since the NPS released, so it's also more reflective of current thought and topics and trends in pain management. And it's more in depth in certain areas and covered some things that the NPS did not cover, like access to care, which is particularly relevant. And of course, the CDC guidelines were not out at the time the NPS was developed. Next slide. So how do you get a copy? As Emily mentioned in the beginning of the call, in the pop-up webinar panel on your screen, we have a handouts tab, if you see, and the actual draft copy of the report, a PDF of it, is available there, which you can download either during this call or maybe in the Q&A section, or in the end, we'll keep the webinar open a few minutes so you can download it. So that's an easy way to get it. But we also developed a toolkit at US Pain that if you copy down this URL, you can get access to. And that toolkit has all the essential information you need to know. There's another link to download the report. There's also information on how you comment. Next slide. So this is sort of my guide to kind of how to read the report. The meat of the report is really in the gaps and the recommendations. Those are the things that really are going to be taken forward. And so the important thing is, if you have limited time, is to really read the gaps and recommendations. Believe it or not, we wrote those first, and then the narrative was kind of wrap around. So that's really the essential part of the document. So if you want to go through it more quickly and just read the gaps and recommendations, that's where to focus. And that's also where to direct your comments. For each of the topics, look at those gaps and ask yourself, did I really get to the heart of the problem? And, if the recommendations that are proposed solve the problem in your estimation. Who knows best but people living with pain? And so I really encourage you to comment specifically on what those recommendations are. So I thought we'll take one topic in the report and take a little closer look at the gaps and recommendations. So I chose stigma. It's in section 3 of the report. So if you go to the stigma section, the first gap identified is chronic pain patients may face barriers in access to pain care due to being stigmatized as people seeking medications to misuse. Contributing to this stigmatization are the lack of objective biomarkers for pain, the invisible nature of the disease, and societal attitudes that equate acknowledging pain with weakness. Next slide. So the recommendations from the task force to attack that issue are increase patient, physician, and other healthcare provider and societal education on the underlying disease process of acute and chronic pain to reduce stigma. Chronic pain is not something we're making up. There is a neurological basis to this disease. It can be a disease, and in most cases, when it goes on for years, it is a disease in its own right, and I think that's largely misunderstood. The second one, increase patient, physician, and other healthcare provider and societal education on the disease of addiction. So when people treat pain patients like they're drug seeking at the same time, we don't want to stigmatize people who have substance use disorder. That is also a disease, and it hasn't been looked at as a disease, just like pain hasn't been looked at as a disease. Thirdly, counter societal attitudes that equate pain with weakness through an awareness campaign that urges early treatment for pain that persists beyond the expected duration for that condition or injury. And the last one, encourage research aimed at discovering biomarkers for neurobiological mechanisms of chronic pain. And by biomarkers, we mean objective evidence, like lab tests, like x-rays. When somebody breaks their leg, nobody's questioning whether their leg is broken. There's an x-ray to show it. When somebody has pain, people are constantly questioning us about whether it's real. But if we had objective evidence of it, we wouldn't be subject to that kind of stigma. So I think it's important that NIH really search for biomarkers, and as part of the HEAL initiative that you may be aware of, that is a specific aim of that, which is to look for biomarkers for chronic pain. Next slide. Second gap, the national crisis of illicit drug use with overdose deaths is confused with appropriate therapy for patients who are being treated for pain. This confusion has created a stigma that contributes to raise barriers to proper access to care. And so, we with pain know this, that there is a big conflation between illicit drug use and appropriate therapy for pain. And that really has raised a lot of barriers and now has really, hindered people's access to care. The recommendation identifies strategies to reduce stigma in opioid use so that it is never a barrier to patients receiving appropriate treatment, with all cautions and considerations for the management of their chronic conditions. Next slide. So how do we comment? There are 3 ways to comment. You can submit online through the federal rulemaking portal, which really is the best way to comment, but you can also send an email directly to Pain Task Force, or you can even mail your written comments to the address there. So in the toolkit that we provided, there is a link to the federal rulemaking portal. You can search the web on your own by putting in the name of the task force and getting access to that rulemaking portal, or you can download the handout we have, and that has the link in it as well. Next slide. So here's a screenshot of the toolkit that we created. And again, to get to that toolkit directly, you can copy down this bit.ly URL that's up here on the screen, and you will get that picture that's underneath it, the pain toolkit that we created at US Pain. Next slide. So tips for commenting. Explain why you do or don't think specific recommendations will be helpful to you as a pain patient. Again, we're going to look through those comments and make changes based on them. So the more specific you can be, the better. Try to be direct and concise. If your response is longer than 3 pages, the likelihood is it's not going to be read, because if we got 3,000 comments in 2 weeks, I'm hoping that we get 10 times that much if people with pain are paying attention and really care about the future of treatment. We got to respond, and keeping it really concise is important. If you have studies or statistics or figures, consider citing them, or citing what data you're talking from. If you'd like to address a specific section of the report, again, cite it up front. I'm talking about the section on stigma or the section on alternative care. Include your name and contact information in case the task force wants to follow up. Next slide. So I've said it many times during the call, it's really important that people with pain write in and respond. We are going to review those comments. The more patients who write in, the greater its impact. Now, quite separately from the portal, which you can be very specific on, it would also be fantastic if people with pain want to write to Secretary Azar, literally write emails or letters. You can look up his address online, or your member of Congress, because they know that this was a part of CARA, and thank them for the creation of the report. Again, resources are devoted to this. A lot of high-level government officials were at our meetings. At the first meeting, the Secretary of Health and Human Services was there. The Secretary of Health was there. The Surgeon General, the Commissioner of the FDA, the head of the VA. So, it's the first time people at that level are really caring about pain. And I feel like it'd be really important for us to thank them for placing the emphasis on pain, wanting to know what the pain community thinks, and considering pain at such a high level. So it'd be great if you did. If all he hears is criticism, I don't think they're going to be too happy that they have done the effort to do this. So it would be really great. And if you do have criticism, the best thing is to save that for the portal and to write into the Secretary. Next slide. So there is the bit.ly URL again to our toolkit, and I can take questions.
Great. Thank you so much, Cindy. That was really helpful as an overview. I know it's a lot of information to process. So I'm looking through the questions here. One question that I got was, overall, as a pain patient, do you think this report is a positive thing for the pain community?
I do. I really do. Look, could the report have gone even further with some things that we want in the pain community? Absolutely. But I really feel like they took patient, emails and calls and letters seriously. And in particular, I think the individualization of care focus is really important. Pain is complex, and it's often not viewed that way. I think that the review of the CDC guidelines was important to do. Things are very political in this environment during the opioid crisis, and a lot of what government officials are focused on is trying to reduce substance use disorder, and that often gets conflated. But in this case, they were willing to take on the CDC guidelines, which have been very controversial, and diplomatically go about saying what needs to change about those. And in particular, this fixation on any individual dose is crazy. Everybody's different. Everybody's metabolism is different. To cut people off at a certain amount of dosage is crazy. So I think on the opioid front, it went further than anything else has done in supporting people with pain who do get relief from opioids. And then, in encouraging alternative care and encouraging multimodal treatment, I think that's really important. It calls out CMS in the report to cover more alternative therapy. In fact, the chief medical officer of CMS was at our meeting and subsequently attended an IPRCC meeting. And I now see that as a result of a lot of this discussion of what was, going to be in the report, it looks like CMS is now seriously considering covering acupuncture for back pain, which they've never done before. So I think in terms of alternative care and getting other things covered, that it was positive. So I really do think this is a really positive thing for the pain community.
Great, thank you. One question this might be, I'm not sure if you'll be able to answer it, but a couple of people have asked, it sounds like this report is suggesting a more, case-by-case approach to opioids. But some folks are asking, even though this report technically would perhaps override the CDC guidelines, it sounds like, a lot of doctors apparently are afraid of the DEA, and which is not necessarily a health agency. Do you think this report will change that at all?
Well, the thing that really got doctors afraid in many cases was both the fact that the CDC guidelines came out, they were from the government, and they set a dosage threshold, and that they hear so much from political leaders about cracking down on opioids. So I think that's why it's really important for people to show appreciation for this report. I think that the best thing you can do is write in and say that you're glad that this reviewed the CDC guidelines. You agree with the fact that there shouldn't be any dosage limits, that people shouldn't be forced tapered. The more people write in support of that aspect of it, the more you contact your congressperson in support of that aspect of it, the better it's going to be. I mean, the way to push back on the DEA is to have, sort of a resounding reaction to this report that won't, that basically says to them, this is being sanctioned by HHS, so you got to, lay off doctors. I think, the only thing that's going to change is if an overwhelming majority of people with pain speak up. I can't emphasize enough how important it is to call your representative or senator and talk about what's important to you. If you're happy with the comments about opioids in this report, tell them that. Tell them your situation and why it's important. I mean, they need to hear from more people with pain. When we go and we meet with lawmakers and we say there's 50 million people in pain, they ask me why I'm the only one here if there's 50 million. Why haven't they heard from more people? So the only thing that's really going to change this is, support for that aspect of the report through comments, through letters, and through calls and emails to your congressperson.
Great, thanks. Another question from someone who was actually at one of the public meetings, but she's talking about multidisciplinary treatments and multimodal care, and asking about, how the report recommends getting insurance companies to cover those treatments, especially in the case where insurance companies might not have evidence yet that those treatments are evidence-based and use that to deny coverage. And sort of she's talking about, the high out-of-pocket costs for those types of options that are not accessible to a lot of people. Do you think the report does a good job of addressing that issue?
Okay, so there's a difference right between the public and private payers. So the government can obviously control the public payers, which in this country, for people that are disabled, people that are elderly, that would be Medicare, and for people that don't have the resources to pay for their health care, that would be Medicaid, and that's a large section of the population, and in particular a large section of patients who have high impact chronic pain that are potentially disabled by their pain. So the report, with its focus on CMS, meaning Medicare and Medicaid, has the ability to basically get the attention of CMS and say, look, we got to start thinking of covering these things. And CMS is getting pressure about that now. They realize they need to go further and do more, and that's why I just mentioned that they're now considering covering acupuncture. CMS is included. There was, as I mentioned, the chief medical officer from CMS attended the meeting, and so they, are getting pushed in that direction. As for private payers, I think that the more this report gets out, gets considered best practice, gets considered, federal guidelines from HHS, the better it's going to be to put pressure on insurers to cover more things. Another thing I can say about that is insurance is, in this country, insurance is regulated at the state level. So if you want to have direct effect on what insurers cover, I encourage you to get involved in advocacy at the state level and do the kind of thing that we did in Massachusetts, which a bill just passed that I worked a lot on here, which will require insurers to have a pain management plan and cover, according to the statute, the language is a broad spectrum of pain management services. So that will take a while to implement, but it essentially forces private insurers to begin covering alternative care.
Great, thanks. Another question we've gotten from a couple of people. Do you feel like the fellow task force members were receptive to the importance of individualized care? And do you think the report will be successful in trying to promote that?
I do think the task force was highly supportive of individualized care. Otherwise it wouldn't have come out so strongly in the report. Also, I think Dr. Singh, I've been very impressed with Dr. Singh. She's a pain doctor with experience, and I feel like she has the patient at the center of her considerations. She ensured that there was a patient panel at both of our meetings. We are really lucky to have, it was our lucky day when a pain management doctor got appointed to be the chief medical officer at HHS. We've never had a pain doctor in that position, and that's another reason why this report is important. She has done a lot of work to be sure that the powers that be, the important people, were at this meeting and are looking at this report. But we can do our part by having an overwhelming response to it. And so if every person living with pain wrote in and said, I support this report because of the individualized focus on care, they would get, millions of emails and letters and calls that they can't ignore. There's a huge power in the patient voice. You might not think so, but really, every individual makes a difference. My example is a good one. I'm a person living with pain. I'm not afraid to speak up. And I think the people with pain really need to respond to this report and really need to speak up while we have their attention, if you care about some aspect like the individualization of care in this. This is our opportunity. We're not going to get many like this anymore if we ever get another one.
Right. Thank you. Another question was about whether the report gives a good picture of the individual and societal and financial burden of pain. Does it have statistics and data on that?
It doesn't, because the report's main focus was not on epidemiology. The report's main focus was on what needs to change. What are our recommendations? We get that there's a lot of people living with pain. I think that message has gotten out between, the IOM report, which started in 2011, then the National Pain Strategy, which also got a lot of attention, and then just this September, as a result of the National Pain Strategy, we had questions on the National Health Information Survey, which is a comprehensive survey of the American populace that the CDC does every year. We got questions about pain and high impact chronic pain on that. And so we got the most accurate numbers we've gotten to date in September, when the CDC and NIH reported that 50 million Americans live with pain. That is a very solid number. That is like the best number we've gotten to date. It's better than the IOM report number, because the IOM report was done with putting lots of different studies together. This actually asked the questions. People, like 30-some thousand people, answered that question. And from statistical analysis, they know that that's an accurate number. So 50 million people have pain, and 19.6 million people live with high impact chronic pain. If you haven't read that study, then contact us at US Pain, and we'll make that study available. That was really the important epidemiology, and that should continue, and that's like another topic. But this report was really focused on care. What needs to change about care? And that's why it will have the greatest impact on people living with pain now. It's not a future report. It's not a strategic report. It's a clinical report about what needs to change. And, it does need to change. It should have happened yesterday, but it's in the report now, and let's just jump on it. Let's jump on it.
Great. So we have a lot of questions coming in. So Cindy, if it's okay with you, if we go like another 5 minutes of questions, is that okay?
Yep. No problem.
Okay. So someone was asking about the term chronic relapsing pain condition that is used by the report. And she raises a good point about chronic relapsing makes it sort of sound like people with severe pain might have periods of remission. And that's not necessarily true. Some people have pain 24/7 all the time. Is that what the report was saying? Or, can you kind of explain that term and what it means?
Yeah, I'm trying to get back to that section, and I know exactly what you mean. I think that what they mean by that is conditions, very specific pain conditions like sickle cell, which does have that kind of a pattern, as I understand it. Where you have periods of intense pain and then periods of very little pain. That's not the predominance, of chronic pain. Most people with chronic pain have pain, in either all the time and then it spikes, or all the time at a low level and then it gets high, or all the time intense. So I think that term was very specific for certain conditions. But I know that was in there, and I'll go back and look at that. And I think that's a good point to comment on that. If it's not clear in the report what was meant by chronic relapsing conditions, and it may not be, I think it's really important to comment on that. That would be a very substantive comment in the comment period. And, you could put multiple comments in. I mean, don't feel like this needs to be perfect when you put a comment in. We got all kinds of letters from people. Just go to the portal and, put in a comment about something like that you see, to make sure that it gets in there and gets covered. So, I don't have the page number right in front of me where chronic relapsing conditions is and how clearly it was explained, but I do remember that coming up, and I think that's a good point. It may not be explained as well as it should have been. Thanks for that question, by the way.
Yeah, that's a great question. Let's see. Another question we have is about, what's the best way to reach legislators? And just to be clear, so Cindy, we have two ways that we're suggesting people speak up about this. And one is speaking up through the federal rulemaking portal. That's, the links that directly goes to the task force. But then Cindy's also recommending that you reach out to legislators to make sure they understand the report and are aware of it, and even including the Secretary of Health. So there's, two separate things we're sort of asking or encouraging people to do. But people were wondering, what's the best way to reach out to legislators? Oftentimes some people are mentioning in their comments that they write in and they just get sort of a standard response. Do you have any advice there?
Yes. Okay. So I think Emily made a really good point at the outset before you even get specific about lawmakers, and that is that we're urging two different kinds of commenting. So when you comment to the portal or to that email or that letter address, when you comment to that, you can be as specific about the report. That's what our suggestions were and the tips for commenting. You can get into the details, like, what do you mean by chronic relapsing conditions? It needs to be defined. My pain isn't that way. Or, I don't like what was said about this recommendation. I think it needs to be expanded this way. Or I do like your focus on multimedia, but, let's be specific about how insurance is going to cover it. Those kinds of specific comments really should go to the docket. That portal that we were given, that federal portal, or the email, but it's best to use the portal. The reason why is because by law, those comments have to be logged in. So there has to be kept a record of those comments, and that anyone can always go back to. And those comments are being looked at by the writers of the report and need to be taken into consideration in the next draft of the report that comes out. Quite separate from that is commenting to the Secretary of Health and Human Services or to your lawmaker, and it's not going to be helpful to write detailed comments to them. They're not going to have read this report. The Secretary of Health and Human Services will have read the report, but your congressperson will not have read the report. The congressperson may realize in the CARA legislation, there was this section on pain management, and this is what the report is from. And so for them, lawmakers and anything you write to the Secretary of Health and Human Services, please don't be specific. It's not going to help us. It's not going to get logged to the docket, and they're not going to know about individual details of this. Those comments need to be more general, like, we like the fact that this report was done, Senator so-and-so. I'm commenting to you today on a report that was done as part of CARA for pain management. I'm glad you focused on pain management. The report emphasizes individual treatment. We really support that and care about it. So you're commenting on the fact that the report was done and highlights of the report. We like the focus on X, Y, or Z. To those people, it would be best if the comments were high level. Now, as far as contacting your lawmaker, the very best thing is to call into the Washington office or to call into the local office. Picking up the phone and making a phone call to them is more impactful than an email. And when you do, you can say, I'd like to speak, if you call into Washington, I'd like to speak to the health policy aide. They all have health policy aides. And there, once you get to the health policy aide, tell them your response to the, thanks for doing this report. I think it's important. We want the senator to know that we want the report recommendations listened to, or whatever you want to say. But, calling in is important. If you talk to an aide, no problem. The aides, you almost will never get to talk to a senator or a lawmaker. They're in meetings, they're in hearings, they're busy, whatever. The aides in the offices, they really matter. I mean, they really are charged with taking call responses and email responses and bringing them to the lawmaker. So it's no problem if you're speaking to an aide. So it's important to try to call in. And then the other thing is, calling in when you're a constituent. They don't care about people that aren't constituents because you don't represent votes. Who does represent votes are constituents. So call your own representative or your own senator's offices. That would be most impactful. If you want to write it in the emails, that helps too. I'm sure they take a tally of how many responses, an email they got about a particular topic. So that matters too. I mean, any communication that you can with them about it is great. I think phone calls are really the best.
Great, thanks. So we're just going to do 2 more questions. For those of you who are not getting to, we're going to keep the webinar open at the very end, and I'll try writing in some responses to some of the easier questions. And then again, we will host probably a second webinar on this next month. So don't worry that, we'll try to get to everyone's questions at some point during the comment period. And you can also always email us as well. The last 2 questions. So one is from someone who's talking about, the report is 90 pages. Thank God it's not 100 long. And, it's going to be difficult for them to read the whole thing. So what do you recommend as far as, what might be the most important section to look at, or, how should they sort of approach digesting the report?
I would look at the table of contents and pick out from the table of contents what you think are the most important things. There's a section on complementary and integrative health. There's a section on stigma. There's a section on access to care. I mean, pick out what you think is most important and go to that section and just read the gaps and recommendations. Just, focus only on what the recommendations are addressing that gap, and ask yourself, I would skip the narrative. It's not that important. The most important thing are the recommendations. Are those recommendations on target, do you think? And if not, that's what you should be commenting on. Comment on the recommendations and comment on, whether you think the gap addresses the topic. Commenting on something in the narrative, is fine, but it's not going to mean anything. What's going to change about, this report and what's going to happen with this report is the recommendations are the important part.
Okay, thank you. And last question, a few people have asked how they can help spread the word about this report, what they can do to try to get more people to weigh in.
Yeah, I mean, we are in the toolkit, Shana created some social media posts. And so the more you can get on social media, Facebook, Twitter, whatever you can to get the word out. It's important for people with pain to respond, and just, as much communication as you can have. Social media is a big help with that. Another thing that's happening is that a number of the patient groups, something called the Consumer Pain Advocacy Task Force, CPATF. I know it's a big mouthful, but there is a website for CPATF, and it includes the core group were 16 patient groups. So US Pain, the Arthritis Foundation, the American Cancer Society, RSD Association, the ACPA. So all these patient groups have been meeting on a conference call and are supposed to all be coordinating our work to write talking points for people and a template letter that we can use. We have till April the 1st, so there is a little bit of time. And so be looking out for, from US Pain or from any of the other groups, be looking out for template letters that you can use, talking points that you can use when you call your lawmaker, or you can use in writing into the docket. And then try to email those to everybody you know, or post them on social media. Anything you can do to get the word out is really critical.
Yeah, and just to add to that, you could, if you're in any online support groups, you could let people know about the comment period. If you're in any in-person support groups, you could share it with them. But we'll keep trying to provide resources and help as well. And we'll also be, always sharing about the comment period between now and April 1st. So feel free to share our posts to help get the word out. So that's all the time we have for questions, because we're going to get to some of our department updates really quickly for about maybe 10, 15 minutes. But I just wanted everyone to know that, I am seeing your questions and taking note of them. And I'm either going to try to answer some at the very end of the webinar via chat, or we'll just take note of them and try to address them at a future webinar. So thank you guys so much for asking such wonderful questions and for being such an engaged audience, and being so interested in fighting on behalf of the pain community. And thank you to Cindy for representing us and doing all this hard work despite your own chronic pain. We really appreciate that. We've gotten a lot of comments from folks saying how much they appreciate you.
Great. Thanks, Emily. Thanks, everybody.
Thank you. Okay, so before everybody jumps off, we're going to just do our few department updates. We don't have too many today, but if you want to hear what US Pain Foundation has been up to, as far as our programs, stick around and we'll go through those pretty quickly. So first and foremost, we have our ambassador update. And Lori, I don't believe, is able to make it today because she is running a support group. So I'm just going to run through these quickly for her. So the first thing she wanted me to tell you guys was that Jeanette Rotundi will be displaying the Invisible Project at the Central State Medical Center in Freehold, New Jersey. I think that's today, actually, from 10 to 6 p.m. Also, Malcolm Herman will be hosting a table at the Community Food Bank Wellness Fair at Mountain View High School track in Southern Arizona, and that's from 12 to 5 p.m. I'm not sure what day that is, but you can check our website calendar for more details, and that's at uspainfoundation.org. And most excitingly, we have the Ambassador of the Year announcement coming up. So we'll be sharing, our most active and awesome volunteer for 2018, and that will be announced in our February newsletter. So keep an eye out for that. So next we have our state advocacy update. Shana, are you there?
Yes, I am. You can go to the first slide.
Okay.
Thank you. So the Advocacy Network's kicking off a new webinar series that's going to really focus on patient education and advocacy. So what more appropriate way to kick it off than to have our first webinar focus on advocacy? And really this is for existing advocates, but also for interested volunteers who want to learn about issues impacting Americans with chronic diseases, including pain. So this webinar will focus on what it means to be a patient advocate, how decisions are made at the state and federal level, tips on building relationships with your lawmakers, ways to advocate, and why sharing your story makes a difference. We're going to be sharing this event via email and social media, so don't worry if you can't see the registration link over there, click on it. We'll be sharing that registration link with you all in the coming days. Next slide, please. We're also collecting patient stories again this year in a number of states. It's really important that you guys start sharing your personal experiences with issues that you've had with your insurance company, for example, or accessing your medications, such as step therapy or non-medical switching, just because it's really giving your lawmakers that patient perspective. It's helping them understand the true impact that these barriers to care can have on their constituents. You'll see here a list of states where legislators really need to hear about your unfortunate encounters with non-medical switching and step therapy. Obviously, they need to hear on issues outside of these, but these are the two that we're starting to focus on at the start of the legislative session. Advocates on the call today should be on the lookout for some email alerts that are coming up soon relating to opportunities where you can share your story or engage on patient-friendly legislation. And then the second bullet point on this slide, just wanted to mention that Illinois has a new law in place. It's called Public Act 100-1052, and it protects families and individuals from non-medical switching. I encourage you all to visit the website that's noted on this slide where you can learn more about your rights under this new law. Next slide, please. Okay, so here you'll see some of the general topics that US Pain is going to be focused on at the state level this session. The three categories would really be access to treatments, patient safety, and fair insurance coverage. For the sake of time, just feel free to reach out to me offline, and I'm happy to share specific issues that fall into these three categories. Next slide, please. Okay, so this is a map that captures a few different pieces of information that relates to medical or just relates to cannabis as an alternative therapy option. Now, the intent of this map is to have you gain a sense for states that have some cannabis legislation in place. And while this map is here on your screen, I just wanted to take a moment to highlight some stats for you because I know that medical and recreational cannabis conversations are going to be brought up in a number of states this year. It's also likely going to be tackled at the federal level as well. The first statistic for you all, just to keep in the back of your mind, is the Pew Research Center noted more than 60% of Americans do support the legalization of marijuana. We have more than 30 states that have some form of legalized cannabis, and then more than half of the states have medical cannabis programs. Now, in the past, US Pain's not focused on cannabis for recreational use, but legalization of this therapy might be monitored by our organization this time around for a few key reasons that are explained on the next slide. Okay, so because a lot of states, and I've listed for you here, just New York, Illinois, and Rhode Island as some examples for you to keep in the back of your mind if you live in those states, they are slated to introduce legislation legalizing cannabis. And so we want to make sure that existing medical cannabis patients who are part of the state program don't run into any access issues when it comes to receiving their specific strains that work for their medical condition. And then we also are going to continue, or not continue, but we're also going to start monitoring whether the legalization bills would place any limits on cultivation regulations for legal patients who have been growing medical cannabis for a number of years. Outside of the legalization issue, we're going to continue supporting bills that are introducing medical cannabis programs in states that don't yet have them in place. And then in states that have a program, we just want to make sure that they're including chronic pain as a qualifying condition to open up that pool for qualified patients. Now, just as an aside, at the federal level, I don't know if you heard this yesterday or not, but the Attorney General nominee, William Barr, did say during his confirmation hearing that he was not going to use federal resources to crack down on marijuana businesses in those states that have legalized the drug. So that's positive news for patients, and we'll continue following medical cannabis at the state and federal level. Thank you.
Awesome. Thank you, Shayna. And I just wanted to add, a few people have asked whether the report that Cindy was speaking about addresses medical marijuana, and it doesn't because it's technically still legal at the federal level. So that was just something they didn't get into. So that's why it's so important to, keep an eye on it at the state level. So thank you to Sheena for continuing to monitor that. So next up, we have a pediatric update from Casey. Casey, are you there?
I am.
Hello.
Hello, good afternoon, good morning to some of you. I'm going to give a quick update about the Pediatric Pain Warriors program. First off, we had our first ever retreat, which went off in November down in Disney. We had 42 families who attended, a little over 100 people, and it was an absolutely amazing event. We had doctors who came in and put on a Take Control of Your Pain event for both the children in one part and the adults in another. And we are planning our next retreat for the spring, so be on the lookout for registration for that to come out shortly, as soon as we get everything finalized. And more details will be able to be followed as soon as we have everything implemented for that. The pediatric program is offering our own set of webinars as well, kind of more focused on the challenges that children are dealing with this. And our next one is actually January 28th at 10 a.m. And it is on, we have an attorney coming on to speak about 504s and IEP plans and how to, what to be looking for children, how schools can be helping, and what parents should be getting from each school district. Also, Pain Pals is listed on here, which is kind of just maybe as it seems. It's like a Pen Pals, but we are trying to put together individuals around the same ages who would like to remain in contact with somebody else. Maybe once a month, twice a month, we can, work out the actual logistics when all of that happens. But right now we're just working on pairing up individuals with other individuals, so these kids realize that they're not alone and isolated, and they have somebody that they can talk to. And then we are excited that our 4th annual Points for Pain Games will be happening January 24th and 29th. So they're just a week and a half and 2 weeks away here in New Jersey. Is the biggest fundraiser here for the pediatric program. I'm a little biased because it is my son who created that fundraiser, but we're very excited for that. And exciting this year is the high school that it is actually going on, which will be January 29th. That night, they will actually be live streaming the event. So they're the high school, I guess, camera club, I don't know what it's called, video club maybe, I don't know, but they will be live streaming the event, so that will be exciting. And the brand new Invisible project will be on display there as well. And all of that information and to sign up for Pain Pals or the webinars is listed on our website, and it's listed at pediatricpainwarriors.org.
Awesome. Thank you, Casey. And just so everybody knows, the Pediatric Pain Warrior program was launched earlier in 2018. So it's really exciting to see how much it's grown because obviously having pain as an adult is hard enough, but when you're a kid, there's a lot of unique challenges. So thanks, Casey, for all your hard work there. Just a couple more updates before we wrap up. One thing we wanted to mention was that we're very excited to be participating in Headache on the Hill on February 11th and 12th. We'll be sending some representatives from US Pain to go meet with legislators and talk about issues related to headache and migraine disease and chronic pain. Relatedly, we're also working on our next Invisible project, which will be our 3rd edition about migraine disease. And we're going to be launching that edition at Retreat Migraine in April. So keep an eye out for more news about that. And lastly, but something that I think is really exciting is that we're planning our next support group leader training weekend. And that's going to be in the San Francisco Bay Area. We're not quite sure where yet, but it will be sometime in March. So stay tuned for details about that. We'll have applications for folks. And basically, it's a weekend of training with Glenn Herman from Pain Connection, where you learn how to run your own support group, and you also just learn a lot of tools for managing chronic pain for yourself, but also how to kind of help people cope with chronic pain through a lot of different exercises. It's really an awesome weekend training. So keep an eye out for that. We'll have information on our website and in the newsletter. I'm just going to see if we have any questions here. Let's see. Takes a second to scroll through. Okay. Not seeing any questions on the department updates, but if you have a question at any time, you're always welcome to email us. So I lost my slide place here. Hold on one second. There we go. Okay. So if you haven't signed up as an advocate or ambassador yet, something we've been sort of talking about, those are our 2 volunteer programs with US Pain. You can do that at our website. If you already are an ambassador, you can get credit for attending today's webinar by following this link, tinyurl.com/USPainActivity. And last but not least, I just wanted to make sure everyone is aware of our next webinar. So we have these every 2 months, and the next one's going to be March 19th, and that's going to be about applying for Social Security disability insurance, because we've heard from a lot of our audience members that that's something that really interests them. So that should be really interesting. It's going to be from an organization called All's Up, which does a lot of work in the disability world. And last reminder is that you can always register for our webinars or view past webinars on our website at www.uspainfoundation.org/webinars. So thank you so much for everyone for joining us today. Sorry we went a little bit over our time, but it's a really important topic that we are addressing today. And again, I'm going to leave the webinar open for a few minutes while I run through and try to answer some of the questions via chat. So if you submitted a question, I'll see if I can answer it. If I can't, I'm going to write it down and see if we can address it in a future webinar. And don't forget to download our handouts before we close down, and also take our feedback survey. So thanks again, and we will be talking to you soon. Okay, so I just went through and tried to answer as many questions as I possibly could. If I didn't answer yours, I wrote it down. I'll be sharing it with Cindy, and we'll try to get to those at a future webinar. Again, thanks so much for participating. I'm going to close down now, but if you could just take our feedback survey at the end, we would greatly appreciate it. Thanks so much, and take care.